I think with our new panel, we may want to go ahead, Greg.
No, I apologize. No, we're new panel. We really just wanted to, since we've got some new people on board and different perspectives, we wanted to start out with a short discussion on myeloma and COVID and the experiences that you've had at your facilities and some of the insights that you'd like to share with our patients. So with that, I would invite any of you to start. Maybe Dr. Zonder, if you could start, and then we could go to Dr. Shah and Dr. Hari, and then Jenny will follow up with a few questions.
Mm-hmm. So this has obviously been a source of great concern and attention for clinicians and for patients right now. It's led to major disruptions across medical systems all across the country and really around the world. Myeloma patients as a group, because of their need for ongoing treatment and their often immunocompromised state, it has been a challenge. This is a patient. There's some data that suggests this may be a particularly susceptible patient population, and we get a lot of questions from patients about first susceptibility to the infection, but also outcomes once they're diagnosed with COVID. And the data is not complete with regards to either of these points, but there is a little bit of data to suggest that myeloma patients, face challenges in both regards. We've definitely seen COVID infections, amongst our clinic patients. I have to say that our experience so far is, I don't think, very different than the general population in terms of the spectrum of what we're seeing, ranging from asymptomatic patients who are diagnosed after they were exposed to somebody who had a diagnosis, ranging all the way to fatal COVID infections with all the respiratory complications that we've seen. So it's hard to draw conclusions from the snapshot of patients that any one center sees. Even at the largest centers in New York and New Jersey, meaning that the centers that have seen the most COVID cases, even those programs, you're talking about a few dozen cases of COVID in myeloma patients. No center has hundreds of myeloma patients that have had COVID yet. And so right now there's a large scale, there's an interest in national or international collaboration to try and understand the scope of the problem in myeloma patients.
To echo Jeff's statement, it is a really interesting time, and I think for a lot of us, a little bit of anxiety because we're not sure as physicians and patients what's going to happen. But I will say that I've been encouraged so far, because I think that our myeloma patients are already educated to be careful about their contacts and about being clean and washing hands and all the things that we kind of hammer in all during the myeloma journey. And I think that's helped our patients. And I will say, just from our own experience in San Francisco, understanding that our prevalence is probably a little bit different, for example, than New York City. In our group of 4 myeloma specialists, we've only had, I think, 1 person to our knowledge who had MGUS and was just being treated in the community who has tested positive for COVID. So we don't have that many people who have tested positive for COVID. And I'm not sure if that's because we're not testing them or because they haven't been symptomatic to require a test. But this does give me a little bit of encouragement to pursue treatment for myeloma for the patients that need it, because we know that getting COVID is a possibility, but we know that needing treatment is a definitive thing. That for sure has to be taken care of. So I've been a little bit more, I've had a little more courage to recommend treatment and starting treatment and continuing treatment in the myeloma community for my patients.
Thanks, Jenny and Greg, and thanks, Jeff and Nina, for inviting me. So What have I learned from COVID? So in the previous session, my colleague, Dr. Dakal, was there, and he might have already mentioned this. If I'm repeating, please forgive me. So we had close to 10 patients, but after the first 7 patients or so, Dr. Dakal and us, we decided to write up this, and we just got published in Leukemia on our own experience. So here are my lessons, and I will give you some take-home points for the attendees. So our findings were that myeloma patients definitely seem to be getting COVID at a higher rate, just from the low levels of cases seen in Wisconsin in general. We've had patients with myeloma who seem to be getting it at a slightly higher rate. And that just goes consistent with Dr. Zonder said, i.e. that myeloma patients have a disease that is immunosuppressive at the outset. And some of our treatments also make patients immunosuppressed. So number one take-home point is that be very, very, very careful. Our modern tool set is not helping COVID patients just yet. So the old tool set of quarantine, stay away, social distancing, use a mask, use sanitizer, that myeloma patients have to definitely abide by those rules as much as possible. The second interesting finding that we had is that none of our patients had been anywhere near a hospital in the 3 to 4 week period prior to them getting diagnosed with COVID, suggesting that all of this transmission happened outside of the hospital, and they were more likely to contract it in the community than in a hospital. Third thing, most hospitals are actually have really good preventive measures. In fact, in our hospital, among the cancer patients, we just had 1 patient who was unexpectedly positive, where we think it was a testing that was at fault rather than we suspected, we tested, the patient was negative, we had to retest a couple more times before we got a positive. So we think the transmission happening within the healthcare environment is very minimal, and hospitals have done a good way of preventing it. Therefore, I would echo what Nina said, i.e. that if your myeloma needs treatment, and if that is the risk to you, myeloma is the risk to you, it is probably safe to go to a good hospital and get your treatment. Deferring treatment just because of the fear of COVID may actually cause more damage from the myeloma. On the other hand, if your myeloma is in a very, very long remission, and if you're just on maintenance treatment, you're not visiting the hospital that much, might be a good time to take a holiday and see what happens. And that, I think we've advised that to some patients too. But if you're in need of treatment, please don't defer treatment. That's my advice. Thank you.
And have you seen that? I guess that begs a question for the 3, because you've had all 3 different experiences. Have you seen patients who have delayed or moved to oral options or things like that who are now, maybe that wasn't such a good idea? Or what's been your experience?
Well, it's too short to tell right now because, we
early to
SPEP
tell,
to
yes.
SPEP. So I really like this point that Hari is saying, that this is a time to maybe think of some things that might be more user-friendly for the patient. And, we always talk about myeloma being, a marathon, a disease, and the patients have to do so much. And this is a good time to think about switching a little bit. And I like the fact that we have oral regimens out there. This is a huge deal. And this does mean sometimes our patients can do remote visits, many times actually. And we have labs from local Quest, and there's really no reason for them to drive 3 hours. And I really think this is, if there's any silver lining out of it, it's going to be we're better at remote medicine. I still feel connected to my patients, especially because I can see them. And it's kind of funny because I can see their houses and they can see my office. So I kind of like that. So oral chemotherapy with local labs and remote monitoring is actually becoming a new thing.
Yeah, I agree with that. I have a lot of patients who, for the last several years, have been traveling a long way to come see us downtown. And I have a feeling after this experience, we're going to be seeing a lot of them by telemedicine going forward, because they've realized you can accomplish 90% of what you do by getting local labs and talking like this.
Absolutely.
I think what I think the point everyone's getting at is it's always a question of competing risk, and active myeloma, in terms of life-threatening problems, as far as being a life-threatening problem or being a health issue that has real potential consequences in terms of kidney function or skeletal complications. When it's active, the risk of undertreating that probably outweighs the risk of COVID, or the impact that therapy for myeloma will have on your COVID risk. I agree that oral regimens have been a godsend in this time. But it's also important to remember that in the studies that have compared, ongoing therapy versus fixed duration therapy, although there is consistently a difference favoring continued therapy, it's also important to remember that very few patients who stop therapy progress within the first month or two of stopping. And so, when there is a major health crisis like this, sometimes, the most reasonable course of action is actually just to skip a month of therapy and then resume it when able, when it's safer.
I totally agree with both of those points. And I think what we are all saying is that your own risk is personal, and it's a risk versus benefit calculation, which you need to arrive at with your doctor and see if the risk from myeloma and the need for treatment is high enough to warrant coming to the hospital. And thankfully, most hospitals have taken excellent precautions so that in-hospital spread is minimal to zero at this point.
Great. I'm going to ask one more COVID-related question, and then we'll start our panels, and then we'll do Q&A at the end. But for those who didn't attend the first session, I asked this also of the other panel. Who are you seeing of myeloma patients who are at most high risk for COVID infections? And are they similar to the patients that are being seen across the broad community, the diabetics, the people who are struggling with hypertension or obesity or end-stage renal failure, which does include a lot of myeloma patients, right? Or kidney issues. Is it that, or is it something else?
I mean, just, as was discussed in the earlier session, myeloma patients have, there's a lot of different components to the immunocompromise that myeloma patients have. We know from the broader COVID literature that coexisting conditions, definitely seem to put patients at higher risk. As far as blood counts, lymphopenia, which is low lymphocyte count, may predispose to infection, but also may predispose to a worse course during infection. And many myeloma patients, have low lymphocyte counts. But again, and I'm curious to know what the others will say. I mean, right now, unfortunately, the myeloma data is a little bit incomplete, and we don't, I think being able to identify, beyond myeloma patients who have the risk factors that we think we know about for the general population, it's not entirely clear to me that you can identify a specific subset of myeloma patients otherwise.
Okay, so that was the answer this morning. We need more data.
Agree with Jeff.
Agree. I totally agree.
Add to that at all?
I mean, we don't really have that much experience. Like I said, we don't have that many patients. So I think it's more about your general health right now than it is necessarily just about myeloma. Of course, that is just change your baseline risk, but something that myeloma patients have been great about, especially when they get on these journeys. Okay, what can I do? How can I make this journey better? And a lot of them try to walk and do all the things that we talk about prepping for transplant. And I think those things have actually helped some of our myeloma patients gain control of their global health, and that will probably help them, God forbid, if they get infected with this virus. That's my feeling. I don't have data to back that up.
Dr. Hari, do you have any comments?
Same thing. We need far more data, but the risk is twofold. One is the risk of getting getting COVID. If you have myeloma, I probably agree with everyone that it is higher of contracting that. And the second is getting really bad COVID when you do get COVID. I had an 82-year-old gentleman who with long years of myeloma, got COVID, successfully went home. Whereas I had a 36-year-old lady who actually passed away from a heart attack that happened after the COVID. So both ways, it has gone both ways. It's just, we just don't know what is driving this infection to be really bad.
Yeah. Well, everyone join the study. So we can learn more about this, because we will be doing more follow-up of people because we have very few people in the study, I think under 5 or so, that have tested positive for COVID with the myeloma in the study. And we'll be asking at repeat time points over the next probably year, did you end up having a positive COVID infection? And then we'll be able to tell from there, because I think just the antibody tests are not telling us really if they have or haven't so far. So That's fantastic. So we do have a Q&A. People can, participants who are watching can add their questions in the Q&A. We will have several panel discussions or individual discussions, and then we'll go to the Q&A at the very end. And I already know we won't be able to answer all the questions, but we'll try to do it as much as we can.